labelled a lot. You can do better, just apply yourself. It's lonely.
In parts of Australia, ADHD seems to be everywhere.
If we fast forward to 2024, we see an increase across the whole country.
Some people have called it cosmetic psychopharmacology, where people are actually deciding what condition they have.
In other parts, it's barely diagnosed at all.
I think there are people with a misdiagnosis.
Access to treatment is expensive.
How much did you spend on getting the diagnosis?
Close to $3,000.
A brighter future for the world.
You know, as the saying goes, never ask a barber if you need a haircut, a psychologist if you need therapy, or a psychiatrist if you need medication.
The companies making the drugs are trying to gain influence. 6 of the authors have a conflict of interest. You're one of them.
Now, you know as well as I do that doing a talk for an ADHD pharma company is not evidence of bias.
Four Corners has been on a mission to find out why the numbers of adults being diagnosed with ADHD are soaring. We'll unveil exclusive data showing that skyrocketing cases are concentrated in particular suburbs and states around the country. The numbers are way above the rate of people understood to have ADHD in the community. The question is why? Who is being helped and who is being missed? This is complex because at its heart is a serious condition that needs to be diagnosed and treated with great care. For when it's not, those who lose are people who desperately need help. And those who win are the big ADHD clinics and the pharmaceutical companies cashing in.
So this is a song I wrote about 10 years ago when I was going through a pretty tough time mental health wise, and it's a song that when I listen to the lyrics now, since getting my ADHD diagnosis, it all makes a lot more sense. It's called All I Am. I'm all loose and lost and lazy.
Having ADHD is a bunch of different things to a bunch of different people. But for me, emotional regulation is always something that I've struggled with, especially in response to feelings of rejection, which all makes sense more now, feelings of being left out or othered by people.
Ben Drysdale was diagnosed with ADHD a few years ago in his early 40s.
I have struggled with addiction in ways that other people who've maybe been there with me at the same time have now all quit things. At its worst, it feels like you are clutching at straws in a hurricane. Being a new parent is a big thing that kind of pushes people over the edge of where they can no longer mask in ways that they had spent their life masking before.
There are lots of examples of people talking shit about shit they don't know shit about, that people who are going through late-stage ADHD diagnosis have to battle through.
Once Ben was diagnosed with ADHD, he wanted to spread the word to help other people who might be struggling as he was. Celine Wanjiku was one of the people who was influenced by Ben's posts. She'd already come across him at their children's daycare centre in Canberra.
I had seen him struggling with his kids in the morning as well, and we were both in the same boat. So when we introduced ourselves to each other, he gave me his socials and I went and had a look. I didn't have much problems at school. I was labelled a bright kid. Getting to high school where I needed the discipline to finish my assignments, I got harder. I was just told a lot, apply yourself a bit more, you need to try harder.
Is that a common thing you've experienced where people just don't believe you?
Yes, a lot. And I get stories, people saying, oh, everybody has a little bit of ADHD. Everybody is seeking a diagnosis nowadays. And we kind of get dismissed.
With all the noise around ADHD, it's easy to lose sight of what it really is. No one in Australia is better qualified to define the condition than Professor David Cockhill. He's a psychiatrist who's been at the forefront of ADHD research here and overseas for decades.
ADHD is a complex, we could say, neurodevelopmental disorder. It's characterized by 3 sets of core symptoms: problems with inattention. They include concentration and focus, but also planning, organization, memory, all part of that inattention group. And then hyperactivity, which really speaks for itself. But when we're talking about adults with ADHD, that hyperactivity tends to be more internalized as an inner restlessness rather than the outwardly restless child that people often think about. And then impulsivity, which is a really big issue and often one that's not talked about enough. What's really important for making the diagnosis of ADHD is that those symptoms are there from an early age, generally. They're there across multiple parts of your life, so in different situations. And the really important one is that they cause impairment.
Tell me more about that impairment.
If you've had difficulties in your learning as a child, then often you're not functioning at the same level that you might have the capacity to as you develop further into adulthood.
If you lob ADHD into a conversation, you'll commonly hear something like, well, everybody I know is getting diagnosed. It makes it sound as if ADHD is everywhere. And there's often a hint of skepticism. So it's important to understand what experts believe is the actual rate of ADHD in adults.
In adults, the figures that I tend to stick with are the published figures between 2.5 and 3%. We have particularly poor data for females, and it may be that we're underestimating the amount of ADHD in adult females, but 2.5 to 3% is a figure I'm comfortable with.
Neuroscientist and ADHD researcher Professor Mark Belgrove from Monash University more or less agrees.
So the upper limit by international standards for adult ADHD should be around 2.5%.
Upper limit?
The mean, if you like, would be 2.5% based on epidemiological surveys.
Because Australia doesn't collect figures on diagnosis, researchers use filled prescription numbers as the best indicator of how many people are being treated for ADHD. While it's not a perfect measure of diagnosis, it does provide the clearest national picture of how ADHD diagnoses are changing. The main drugs prescribed are called psychostimulants: dexamphetamine, lisdexamphetamine, brand name Vyvanse, and methylphenidate, Ritalin and Concerta. For years, the rates of ADHD prescribing for adults were rising slowly. But about 8 years ago, something strange started to occur. The numbers suddenly started to increase at an astonishing rate, especially in women.
I'm here at the University of New South Wales, where the Medicines Intelligence Research Programme has been working to provide Four Corners with an exclusive picture of how ADHD medication treatment is evolving across Australia. They've used a fairly new capacity enabled by the Australian Bureau of Statistics, which allows rapid answers to health system questions without breaching doctor or patient privacy. We think the findings are going to be dramatic. Hi, Sally.
Hi, Norman. Welcome.
Thanks for having us.
Please meet Michael Foster
Oh, hi,
from
Michael.
my team.
Hi.
He's going to walk you through the data today.
Thanks very much. Well, let's lead on the way. Wow, Michael, this looks amazing. What have we here?
So this is a map that shows the proportion of adults aged 20 to 65 who filled at least one prescription for ADHD medicines in 2020.
So this is numbers of people.
Absolutely. It's effectively the number of people being treated for ADHD.
Now, what does it look like, say, 4 years later?
Yep, so if we fast forward to 2024,
Gosh.
we see an increase across the whole country.
Across the country?
Absolutely. But we can zoom in. What do you think we're going to see?
Well, we're going to go to Sydney first?
Yeah.
Well, I would have thought the higher income areas, North Shore, eastern suburbs.
Let's take a look.
It's not.
No, we actually see a really different pattern. So here in Sydney, we see the highest rates of ADHD medicine use in adults are in the inner west, in around Marrickville and around the Blue Mountains, and that's at about 3.4%.
So if we're talking about a prevalence rate, the experts suggest is the real one, is about 2.5 to 3. We're at the high end of that in 2024.
That's right.
But there are pale areas as well. Is that the southwest suburbs?
That's right. That's southwest Sydney, and these have some of the lowest rates of ADHD medicine use in adults in the country. I think Fairfield here has the second lowest rate across the whole country, and they're below 0.5% of adults.
So we're seeing big variation.
Absolutely, even within the major cities.
Well, let's look at Melbourne now. And again, I'd have assumed, but now I'm not so confident, that it would be the eastern suburbs of Melbourne.
I think we see a similar pattern here where there's huge amounts of variation.
But it's not the eastern suburbs.
No. So the highest rates are in the northern suburbs around Brunswick and Darebin South.
Gosh, but pale areas as well.
Absolutely, huge amounts of variation.
Now, let's go back to the big map, if you don't mind, because we didn't talk about something that stood out to me like the proverbial Western Australia.
13 of the top 20 geographic areas are all located in Western Australia.
Gosh, so it's really dense. So it's the hills area and the suburbs nearest the coast. What is going on in WA?
It's a really good question.
The hottest of ADHD hotspots in Australia is here, Fremantle. The big question is, does that mean there's overdiagnosis? Our data show that Freo is at the higher end of what the experts judge is the rate of ADHD in adults. But our numbers are from 2 years ago. Since then, prescriptions filled for adults nationally have increased by at least 30% more. So Fremantle might be getting beyond the accepted ADHD prevalence. Either way, what's going on? And is Fremantle a sign of what's to come elsewhere? Our data show that an average of 4.4% of adults in Fremantle received ADHD medications in the year to June 2024. And if you look specifically at women aged under 44, the rate was more than 6%, well over the 2.5% that experts would expect.
I actually struggle to give you a good reason why. I think it's a tough one.
Dr. Kyle Hoth is president of the Australian Medical Association's WA branch and a psychiatrist who sees a lot of ADHD.
WA has historically had higher rates of ADHD treatment, both in children and adults, than other states. And I think with the increase in ADHD awareness and therefore diagnosis and treatment, has lifted the country up as a whole, which has kept WA proportionally ahead.
Western Australia has the lowest number of psychiatrists per capita compared to the rest of Australia, apart from the Northern Territory. So you've got a small number of psychiatrists doing a lot of the prescribing in a very complex area.
I don't think every diagnosis of a West Australian is by a West Australian psychiatrist. We know that there are a number of sort of national telehealth providers that conduct ADHD assessments and ADHD treatment. And so I think that probably muddies the water a little bit.
It's not just psychiatrists making ADHD diagnoses. Clinical psychologists, such as Hobart-based Dr. David Becker, see lots of people with ADHD.
We need to build a comprehensive picture of this person's life, what they've experienced in early life as well as in adult life, and then get the diagnosis of best fit to explore and explain those experiences that they're having.
Do you often say, no, you don't have ADHD?
I think it really depends on where the referral comes from, but maybe 1 in 2, 1 in 3 of these referrals, that person, ADHD is not the best explanation for their difficulties.
But they may have come convinced that it is ADHD.
Yeah.
One of the ways people can become convinced is by watching TikTok or Instagram videos, which aim to share insights into ADHD.
I think social media platforms and an improved awareness of ADHD in society, in modern society, is great to be able to destigmatise these issues. However, if you're trying to communicate something very quickly and in a very small amount of time, then you don't have enough time or the user's attention to go through all of the other issues that might be going on.
So what we've done is we've got some TikTok videos, and all we did was search on #ADHD. So should we look at this one? Says, how to spot ADHD in women in 25 seconds.
They'll get obsessed with someone or something and disappear from friends for months at a time. When they achieve something, they won't feel any sense of accomplishment, only a mild sense of relief that it's done. If they have a minor commitment later on today, they won't be able to relax and they'll be stuck in waiting mode all day. They have a really...
Can you spot ADHD in 25 seconds? I mean, it's a pretty short consultation.
No, and I think there are many reasons why someone might be having those experiences. So sometimes there is an over-pathologising of experiences that people have.
Let's try another one.
Here's a very interesting observation I've made as a therapist for ADHD with ADHD, is that people with ADHD always feel like they have so much to do. They have such a huge to-do list. They have so much to do. It is so overwhelming. I can't possibly do it all. But like neurotypical people don't see life that way.
Really? I feel as if I've always got a lot to do.
Yeah, I do too. So I no doubt many people with ADHD feel that way. They feel like they've got so much to do. But also there are many people with ADHD that don't necessarily feel that way either. So it's not really a good sign of anything.
Some people have called it cosmetic psychopharmacology, where people are actually deciding what condition they have. They go and seek a clinician who will reinforce that or validate their particular view of what they have and then treat that.
Nick Glosier is Professor of Psychological Medicine at the University of Sydney and has had a long-standing involvement in ADHD treatment.
What stands out for me in the prescribing rates, and I think here we're looking at time trends, so what's been going on? The increase across all forms of psychostimulant medication. Now that may match the increase in the rates of prevalence. It doesn't, it vastly exceeds prevalence.
Professor Glosier argues that the absence of a definitive test for ADHD, such as a blood test, means that diagnosis often comes down to a clinician's subjective view.
I think one of the difficulties is, of course, that these symptoms are not diagnostic for ADHD. You know, problems focusing, problems with attention, problems with your memory. These cognitive symptoms cut across every single psychiatric diagnosis. They cut across depression, they cut across anxiety.
To make sure you have it right, the diagnostic process for ADHD is actually quite involved and lengthy.
You have to identify the various symptoms people might have. You have to identify when they came on, how disabling and impairing they have been over your life. Not now, you have to go back over people's lives. You have to identify how they affected the person when they were a child and as a teenager. You have to preferably try and get collateral information from people who knew them in their younger stages, or even better, written information. You then have to exclude all the other causes of what could be going on.
The big question is what explains these truly enormous variations in treatment and, by implication, diagnostic rates of ADHD from far above the prevalence rate of 2.5 to 3% to far below. Because in theory it shouldn't happen, since doctors are supposed to be using the same evidence base. In 2022, the Australasian ADHD Professionals Association, or ADPA, released a guideline which was intended to be the foundation of ADHD diagnosis and treatment in Australia. It's called the Australian Evidence-Based Clinical Guideline for Attention Deficit Hyperactivity Disorder. Professor Mark Belgrove ran the group which created it.
We've had a long period now where there's been increasing awareness of ADHD. I think part of that has been attributed to things such as the guideline that we've developed, but also inevitably through COVID and the TikTok influences, etc. TikTok gives you a very narrow perception of what ADHD is and what a diagnosis of ADHD likely entails. A diagnosis requires impairment. In fact, without impairment, there can be no diagnosis of ADHD. And I think that is the difficult part for clinical diagnosis.
The guideline is called evidence-based, but when you go through the 113 recommendations, in fact, only 12 have any evidence, and most of those are rated as having low or very low certainty. Many of the other 101 recommendations are by consensus, opinion-based agreement amongst experts. It's the lowest of the low when it comes to level of evidence. It's not as if this was hidden. It's all explicit in the guideline. The question is whether the title is merited.
Well, I can assure you there's nothing nefarious about the labelling of the guideline as evidence-based. Sometimes there's just not enough studies in the space. This is very, very typical.
The guidelines were approved by Australia's peak health body, the NHMRC, which confers a high degree of credibility. CEO Professor Steve Wessling believes the Council's process ensures guidelines are up to standard.
It is important because I think it's the gold standard of guidelines in Australia. And I think the Australian public are keen to understand whether a guideline has gone through the formal process that we deliver.
And it says evidence-based, and it's NHMRC endorsed. You think, oh, well, this is good, it's evidence-based. But it's actually not evidence-based, it's opinion-based by and large.
We are comfortable that the recommendations can be consensus, but they have to state that they are, and in this case they do.
The uptick in ADHD diagnoses coincided with the availability of psychiatric consultations online. There are now large companies that focus significantly on ADHD, and it's not cheap. It can cost people thousands of dollars. And that translates to psychiatrists' earnings. One job ad at the top end that we've seen could add up to an annual income of over $1 million. Are you worried about the quality of care and diagnosis that people are getting from telehealth companies?
I'm not specifically worried about telehealth as a vehicle for clinical assessment. They shouldn't just be doing an ADHD assessment. That sort of doesn't exist. The clinician needs to be making an assessment of the person in front of them and the full complexity that is before them.
There are many telehealth psychiatrists who endeavour to be thorough and evidence-based. However, a feature of the initial assessment is often a questionnaire which you fill out before seeing the doctor.
You can't diagnose ADHD with questionnaires. Questionnaires are not accurate enough, and they do lead to what we call a lot of false positive recognition of ADHD.
And yet a lot of these telehealth companies seem to be relying on these questionnaires.
They do, and that's a concern. We hear a lot of feedback from people living with ADHD that their assessment has been very quick, but it's really consisted of just filling in those questionnaires, having the doctor look at them, and then having a rubber stamp. That's not acceptable.
Four Corners is aware of people who had assessments by some doctors at telehealth clinics Docatella and Fluence, which were short, and who received psychiatric reports with significant inaccuracies. Docatella told us it knows of a small number of inaccurate reports, but that full clinical responsibility lies with the consulting psychiatrist. Both clinics refused an interview, and Fluence asked us to cease communication.
We're getting reports of big telehealth companies not doing the right thing. Has that been your experience?
Unfortunately, it has been. Some of the assessments that I've seen and coming through, I suppose I would question how deep the assessment has been and whether some of those other differential diagnoses have been considered or not.
Having undiagnosed ADHD, finding out when you're in your 50s is completely heartbreaking because you have a massive grief around all that you've lost.
Amber Davis lives in regional Queensland and had to drive to Brisbane to get her diagnosis. She later moved to telehealth consultations and feels her care was substandard.
Did you feel that your psychiatrist understood ADHD?
It's impossible to know that because we really didn't talk that much about ADHD. I didn't feel that I was with an ADHD specialist by any means. There was absolutely no advice or support in regards to managing life in conjunction with medication. It was like, here's your medication, see you later.
Amber had serious side effects with her first medication and found that it was up to her to drive the conversation with her psychiatrist.
And the conversation would be, hi Amber, how can I help you today? Hi, I need to get a repeat on my script. Oh, what is that again? And I'll repeat, it's Vyvanse. Okay, we'll get that sorted.
Amber also noticed there were discrepancies between the actual duration of her consultations and what was being billed.
My assumption is that if a psychiatrist is being paid for a 45-minute session, is that their patient will have a 45-minute session. Apart from the first two consultations, the following consultations for repeats on scripts were no more than 5 minutes on the phone. I just kept getting a feeling, it's like, this is not right. We're going to do $315 for a few minutes on the phone. I'm sorry. And yeah, it concerned me deeply.
After diagnosis comes treatment, usually psychostimulants and predominantly amphetamines. They had an immediate effect on Celine Wanjiku.
When I started the treatment, I noticed that my mind was quiet. It was a pleasant experience, especially the first time. I'll never forget that. I usually say that my head is full of a bunch of squirrels running around. And once I took the medication, everything was quiet. It's like the squirrels were in a line and tackled one thought at a time. And it was the most amazing experience.
It's fair to ask, so what if the prevalence of prescribing exceeds the prevalence of ADHD? What harm is there? Well, a big potential harm is from getting the diagnosis wrong.
My name's Jackie Huber. I'm an emergency psychiatrist and I work in a dual diagnosis psychiatry and substance and toxicology unit as well. There are many illnesses that can, if you don't look carefully enough, look like ADHD. That might include mood disorders, personality disorders, trauma-related sequelae. And if you don't catch those diagnoses because you're diagnosing ADHD instead, those individuals won't receive the treatment they need, and that's poor practice.
Then there are potential harms from the stimulants themselves. For example, high blood pressure, a rapid pulse, anxiety, insomnia, and weight loss. But one of the more worrying, albeit rare complications, particularly in people who are taking high doses, and sometimes along with recreational drugs, is psychosis, a frightening delusional state involving high emotion. Nobody's collecting the actual statistics in Australia, but we've spoken to emergency doctors in 3 states who are concerned about ADHD medications causing or contributing to a rise in psychosis presentations.
The trend in psychosis is increasing. Unfortunately, I don't have data for you, hard data, but I can tell you unequivocally, the people who have been prescribed amphetamines coming through the door, that proportion has certainly increased.
Do you ever have problems finding out where they've been diagnosed, and because you've got to refer them back?
If someone has received an ADHD diagnosis by a clinician who works face-to-face, generally speaking, the practice has a phone number. That's different in the telehealth space. Some telehealth clinics have, for instance, solely like a page where you fill out your details online and they say, we'll get back to you in 48 to 72 hours.
Dr. Daniel McMullen is a general practitioner and federal president of the AMA.
Right across the country, the AMA has heard reports from our emergency department and psychiatry colleagues about a concerning increase in psychosis presentations, potentially due to psychostimulants and ADHD treatment. That really is a worry. These are not low-risk medicines, and the side effects or adverse events related to these medicines can be severe. A psychotic episode is dangerous, it's scary, and it's not a position patients want to be in.
The national regulator for clinicians is APRA. It told Four Corners that in relation to ADHD, it's seeing growing numbers of complaints about alleged inappropriate, unlawful or inaccurate prescribing, incorrect or delayed diagnosis, and poor communication. As a result, more than 55 practitioners have had action taken against them or are in the process of disciplinary hearings, such as a Victorian psychiatrist who was struck off for inappropriately prescribing dexamphetamine to a patient, despite being aware it was a likely contributor to her psychotic symptoms. The medication that dominates ADHD prescribing in adults is lisdexamphetamine. The brand name is Vyvanse. Its growth has been spectacular over the last 5 years since it was put onto the Pharmaceutical Benefits Scheme for people diagnosed as adults. And it's now the fastest growing medication subsidised by the government. The government's expenditure on Vyvanse has increased from $32 million in the year ending 2020 to $168 million last year. Takeda, the manufacturer of Vyvanse, has spent tens of thousands of dollars in Australia over the last few years, paying doctors to be on an advisory board and speak at events. It's also been a sponsor at the Royal Australian and New Zealand College of Psychiatrists conferences. It's given money to the country's main consumer groups, ADHD Australia for educational programs and the ADHD Foundation for a national helpline. It's also paid for a national masterclass of ADPA's new guideline, and it was the major sponsor of the last 4 ADPA conferences.
Takeda is a global biopharmaceutical leader headquartered in Japan.
pharmaceutical funding for conferences and doctors is commonplace across most specialties and occurs especially when a company has drugs which are still in patent, which means there are no generic competitors. In Australia, Vyvanse is one of those.
Better health for people and a brighter future for the world.
Pharmaceutical companies know what to fund in order to increase prescription practices of whatever agent that they're currently marketing. So by funding consumer groups, by funding continuing medical education, for example, it's a very robust way to be able to influence how many drugs are sold. With consumer groups, it's indirect, but it's still very powerful.
Professor Lisa Cosgrove is a clinical psychologist and an ethicist at the University of Massachusetts in Boston. She's researched conflicts of interest in psychiatry for many years.
People get defensive because the implication is, I've done something wrong. And that's not the case. Identifying conflicts of interest is in no way suggesting that someone has engaged in research fraud or done anything wrong. Rather, the real crux of the issue is that those ties engender inevitably implicit bias. We're all vulnerable to implicit bias, and we're blissfully ignorant of the way in which that implicit bias can be manifest.
Before we continue, I want to be transparent. About 8 years ago, I was paid to give a speech at an ADHD conference sponsored by Shire, which at that time made Vyvanse. I don't believe it's influenced my reporting, but you can make up your own mind. While most of the people who wrote the National Clinical Guideline declared no pharmaceutical conflicts of interest, a third of the research underpinning it was authored by people with disclosed ties to ADHD drug manufacturers. And multiple people who wrote ADPA's prescribing guide, which came out 2 years after the guideline, declared they'd received pharmaceutical funding. The prescribing guide advises doctors on the choice and use of ADHD medications. Professor Dave Cockhill was one of the lead authors. We've been through the disclosure logs. 6 of the authors have a conflict of interest. You're one of them. Half the advisory panel did as well. You yourself, and you've declared it, have taken about $11,000 of money from Takeda. Can we trust the prescribing guide?
In order to develop that guide, we needed people who knew what they were talking about. Now, you're right, I have had interactions with not just Takeda, but with several pharma companies. But one of the things I did with actually Shire before it was Takeda was I was the lead researcher on the trials of lisdexamfetamine, brand name Vyvanse, for Europe, the registration trials. So I know that data probably better than anyone in the world. And I can see the positive side of how you use these medications, but also can recognize the negative side. Now, you know as well as I do that doing a talk for a pharma company, an ADHD pharma company, is not evidence of bias. You've done them yourself.
Yeah, but I'm not writing a prescribing guide.
That doesn't mean that I don't see you as an objective reporter who can look at this in an objective way. I stand by that prescribing guide as an objective view of ADHD medications and how they use.
So the question is then, why, and Takeda would be at the front on this, why are they putting so much money into the industries? They're getting a big return on their investment. Should we be taking that money into the industry for people who are lobbying for it? You're influencing prescribers and you're training.
We're training people to assess and manage ADHD in an evidence-based way, and that's different. We're very clear, the Australian guideline and all of our education is very clear, that medication just forms one part of the multimodal treatment that needs to be offered for ADHD.
Takeda told Four Corners that the suggestion that funding of medical education, patient organisations or professional bodies is intended to inappropriately influence prescribing or drive the use of particular medicines is a misinformed characterisation of how medicine manufacturers engage with and support the healthcare community. Takeda also said that its primary objective is to improve patient outcomes. One of the most striking points to emerge from the geographic breakdown of data that we've shown you is that there's an enormous public health issue for Australia. While there are parts of Australia with an abundance of diagnosis, there are large areas where people, adults with ADHD, are being left undiagnosed and untreated. Here in Fairfield in southwest Sydney, for example, they have a level of ADHD medication dispensing which is only 7.5% that of Fremantle's. In fact, 90% of adults with ADHD in this area could well be being missed by the health system. This must make you angry.
I do get angry about this.
Dr. Tim Senior is a GP who practices in an Aboriginal medical service in southwest Sydney.
This is one of the things that I see persistently across the work that I do in terms of the patients that I see are Australian citizens with as much right to care as any other Australian citizen, and yet time and time again we see limited access to specialist care.
Just like there are harms from too much diagnosis, there are definite harms from not having access to diagnosis in the first place.
People living with ADHD much more likely to have problems with substance use disorders. People with ADHD across the lifespan have more accidents. If your ADHD isn't diagnosed until you reach adulthood, the mortality rates are 4 times higher than they would be for someone without ADHD. Really striking. ADHD is not a benign condition.
Most state governments have attempted to address the access gap by enabling authorised GPs to prescribe medication for people who already have a diagnosis, and, usually with special training, to do the initial assessment and diagnosis as well. So you'd think that this is an opportunity for general practitioners in your area to become trained, to become diagnosticians and prescribers. What's the reality?
What I'm hearing from my colleagues is that GPs are worried that that'll result in expectation to do long consultations that are bulk billed for difficult ADHD assessments and ongoing care. And the Medicare system funds shorter consultations quite well, but longer consultations much less well.
So the risk is that GPs taking this on doesn't do anything for the gap, might even widen it.
So I'm worried the incentives aren't there and that will worsen the gap. GPs taking it on in better off areas will be able to charge co-payments to patients and not hit practice viability. In areas where most patients can't afford a co-payment, that can be a big hit to practice revenue for employing practice nurses, receptionists, practice managers, and could affect the viability of a practice in areas where patients can't afford to pay a co-payment.
AMA President Dr. Danielle McMullen agrees it will be a challenge for GPs to make this work.
It is likely that under the current structure of Medicare and rebates in general practice, if long consultations or significant out-of-consultation work are needed for ADHD diagnosis and management, patients may face out-of-pocket costs, but it's really difficult to provide this long comprehensive care in a bulk billed way under the current frameworks.
What's clear is this. In some places, people may be diagnosed wrongly. In others, not diagnosed at all. The question is not whether ADHD exists, but whether we're getting the diagnosis and treatment right. Because ADHD affects people socially, psychologically, and economically. So it deserves much more scrutiny.
I do sometimes wonder what my life would have been like if I knew this earlier, mostly for the better. Because if I did know this when I was a child, I probably would have gone to uni. I probably would have had lots of support to get through these big hurdles. And I wouldn't have been ignored for so long.
So you're going to go to uni now?
Hopefully. I've got 3 little kids, but hopefully I would like to go back.